Hello class, this is Professor Eric Lobel. I'd like to just go over the image quality characteristics PowerPoint. Well, we're going to talk a little bit about all of the factors that control density, contrast, detail, and distortion, and give you some examples and what are the influencing factors of each. When we talk about radiographic density, simply the definition is the amount of blackening on a film. And keep in mind that for the majority of this lecture, we are in the screen film world, so we are talking about cassettes with pieces of plastic film in them versus the digital world of CR and DR. And if you look at these two images below, you can obviously see that the left has less blackening and is thus a lighter image compared to the one on the right. Here, three images of the skull, very easily seen that there is less blackening on the left side versus the right side, with the middle side being somewhat optimal, meaning acceptable. Now, we have our primary factor, which is the one parameter that we should use to actually alter the density. That's not to say that there are many other parameters that we're going to see that can change density, such as, KV or screen speed, but this is the one that we want to choose. So, milliampere seconds is our primary factor. And if we increase mass, which is really if we increase the combination of MA or time, we're going to see that density is going to increase. Now, there's also a dose relationship to a lot of these parameter changes. And in this case, it's directly proportional, where dose will go up as soon as mass goes up. In fact, it doubles. If you double mass, you double the dose. So overall, density is affected by a lot of different parameters. We just mentioned that MA. Increasing MA will increase density, or time, or any combination thereof. KV will increase density as well, but please remember that KV is the controlling factor for contrast. So if you utilize KV to try to change your density, you will also be affecting the contrast, whereas when you utilize MA and seconds, or mass, you are only affecting the blackening on the film without causing any other image quality characteristics to change. SID, or source to image distance, will change the density simply because more or less photons will actually reach the image receptor. Source to image distance is the distance between the tube and the image receptor. If you increase the SID, there is an inverse relationship in that longer SIDs, in other words, the tube further away, will cause more photons to die in the air and just not make it to the image receptor. Thus, they will cause a lower density or less blackening of the image. Intensifying screen speed also has an effect on density in that if the intensifying screen speed is known to be a faster speed, it will cause a higher density. In other words, faster screen speeds, or faster film speeds, as we'll see, have a relationship in that you don't need as much exposure to cause the same level of darkening as you would with a slower film or slower screen speed, which requires more radiation. So with the two of these, at this point, I just want you to understand that if you were to do an experiment where all you did was change the screen speed, everything or other parameters being kept the same, changing the screen speed to a faster speed, even at the same exposure, will cause a subsequent darker image as a result. and developer temperature. As the temperature of the developer is increased, our density will also increase. This can generally affect us in the opposite way if you think about it. If you're waiting for your developer to warm up, but you just can't wait and you develop a film, that film would typically be lighter than if you wait for your processor to adequately warm up. And patient factors. Please don't read into this. All this is saying is that if the part is thicker, you will attenuate more radiation, which means that the image will cause a lighter density. What we're not saying here is what you should do. The fact is, if the patient is larger, you would need more radiation. Here I'm saying if you did not change the radiation, what would happen if you took two images, one with a larger patient? And of course I mentioned dose earlier. So SID to review, if we increase our source to image distance, then we are going to reduce our density. So there is an inversely proportional relationship here, and it's inversely to the square of the distance in terms of dose. What this means is if I half my distance from, let's say, 72 inches to 36 inches, I am not just going to increase my dose or double my dose, I am actually going to quadruple my dose. In other words, the dose will go up 4 times. If I double my SID, and let's say go from 40 to 80, my dose is definitely going to go down, but it's not going to go down halfway. It's going to quarter. Essentially, if I had 8 mass to start with, I'm really now giving the equivalent of 2 mass. In the CR-DR environment, density takes on a different role. No longer do we really even call it density. It's actually known as brightness. One of the issues in CR-DR is that the blackening of an image that's usually caused by the amount of radiation exposure, i.e. when an image comes out of a processor, you know you've overexposed it because it's dark, or you know you've made an underexposure because it's light. This is not the case. Density in the digital world has been uncoupled, really, from the exposure, and the tendency is for radiation exposures to actually increase in the CR and DR world because of what's known as noise. Noise is a grainy, granular image, and it turns out that in digital systems, the more mass that you will use, in other words, the more dose and exposure that you use, the less noise you will receive on an image. So the tendency is to increase dose. It's called dose creep. The dose tends to increase over time. So moving on to contrast. Contrast is simply defined as the differences in the blackening of the image at adjacent areas, or the differences between densities. It's usually described as either high contrast, which is also known as short scale, or long scale, which is also known as low contrast. And typically in a high contrast image, or short scale, you have less grays, but the differences between them are bigger. In a long scale contrast image, you can depict and indicate more grayscales. In other words, there are more grays, which means that the difference between each set of gray is smaller. On the left, we have an example of high contrast. The difference between the two is large, whereas lower contrast will show you a smaller difference between the two grays. And there is no right or wrong. I don't want you to associate high contrast or low contrast with being either good or bad respectively. They each serve a purpose depending on what you're looking for pathologically. And in general, we use a high contrast image when we are working with extremities versus a low contrast image if we are trying to depict multiple numbers of tissue types, in other words, more anatomy. In terms of contrast and the way it looks, a short scale image, as the knee on the left is a more black and white image, jumps out from the screen at you, whereas the image on the right, the low contrast one, a little bit grayed out, which is why in some cases long scale images look kind of worse. They're a little bit washed out. They sometimes look as if, they've been subject to too much scatter. We're going to prove contrast in the lab very easily by altering our KV and then X-raying a step wedge. By doing so, we can count the number of steps and determine if we see more steps, that would be a longer scale. The primary factor, again, for contrast is KV, and basically, if we increase our KV, we reduce our contrast. The opposite is true as well. If we reduce KV, we are looking to increase our contrast. In that case, when I say increase, I'm talking about a high contrast image. And contrast has many parameters that affect it as well. We mentioned KV is the controlling factor. Also, some film is manufactured to provide a higher or lower contrast. The developer will also affect your contrast, usually if there is something wrong with it, like the temperature is too high. And there are many other factors, such as the patient as well, such that larger patients really reduce contrast. And really this is indirectly related to the fact that you have to increase KV if you have a larger patient, which will then increase scatter, and scatter is really a contrast killer. So when it comes to scatter, scatter up, contrast down, and anything that can be done to reduce scatter will increase contrast. So in review, a short scale contrast is more black-white, jumps out at you. It's designed so that you really bring out the differences in the densities as easily as possible. Lower KVs in the 40-50 range. Generally, we're using short scale for extremities. Long scale, here you can see looks like it's a little grayish, washed out more, but as you can see, there's a lot of different anatomy that you can show. We see the spine, we see the ribs, we see air, we see the calyces and ureters going down with contrast filled in them. So you can actually depict a little bit more types of anatomy. The idea here is different parts of the anatomy will attenuate to a slightly different degree than others. And if you want to indicate each one, you need several different grays to do so. Typically, we can have more than 1,000 different types of gray. Now, our eyes may not be able to perceive that many, but it is possible in the digital world, and in addition in the screen film world as well. Down here is an example of if we were to X-ray our step wedge, the kind of images we might get if we were to alter our KV. You could see the one in the middle here. You can really only count the last 3 steps. Everything kind of fades out here, so that's a very high contrast image. Short scale, there just aren't as many scales of gray to look at. Now in the digital world, contrast can be manipulated just as easily as density is, and there are some vocabulary terms that I want you to remember. Basically, to review, in density, we can call that altering the level. So there is a button up here in the corner, or a slider, which will change the amount of blackening on the image, except in the CR world, density is known as level. And in the contrast area, we can adjust the contrast by setting what's known as the window. So it's very often common to refer to this type of digital alteration as windowing and leveling. When it comes to detail, this is our third parameter that we're going to discuss. You have what's known as recorded detail, and then you have the visibility and sharpness of the detail. But as a definition, we are looking at the fine structures on an image. How sharp is it? Keep in mind that if your density is too high or too low, or your contrast is off, then you may not be able to see your detail. In the digital world, detail is no longer called detail. We now know that as spatial resolution. But to break detail down, you have what's known as the visibility of the detail. And this is controlled by your radiographic density and contrast. In other words, if, as I said, your density is too high, for example, then you won't be able to visibly see the detail that is lying beneath this blanket of dark density. And the sharpness of detail is based on your contrast, but as it relates to the imaging system that was used to produce it. So if you have a better system, take my word right now that a DR system will give you better sharpness of detail than a CR system. They're both digital, but one is a little better than the other. So it's spatial resolution, it's detail, although we want to move away from that term, is better. One of the aspects that detail looks like is it's somewhat like a blur, similar to what you would see on an image that has motion. So the image here is a little bit clearer, whereas if you look at the image on the right, it has a little bit of a blurry look to it. So if you see any type of blur, that's definitely motion. And as you can see, the fracture here, it's a little bit harder to recognize that compared to the fracture on this side. And this is the type of thing that if your detail is not good enough, you may not make a diagnosis as a radiologist, and that wouldn't prove well for a patient. Now, DR in the CR and DR world, again, is known as spatial resolution, and it's based on a lot of mathematical steps or algorithms that are designed to increase the image. In some cases, it's known as image or edge enhancement. As you can see on the right, there are some QA phantoms that can be utilized to basically test and look for the level of detail that are in an image. There are some geometric factors that will affect detail. The first two, OID and SID, deal with changes of the tube, and they really relate to magnification. So at this point, you should understand that magnification will affect the level of detail in an image, and that the larger an image appears, in other words, if there is magnification, you will be accompanied by a loss of detail. So the image may get bigger, for example, and larger, but that does not mean it's more sharp. OID is actually object image distance, and that is the distance between the part and the image receptor. It has nothing to do with the tube. The example that I've used in class is if I'm standing as a lateral C-spine, you're going to see that my neck is not up against the image receptor because my shoulder is in the way. So when you have an increase in OID, you're actually going to get an increase in magnification, which would cause lower detail. So the object here, or the goal, is to always reduce our OID. The SID is opposite and the inverse of OID, in that if we increase our our SID, we're going to decrease magnification. So increases to SID will minimize the image and will give you better resolution, better detail. Focal spot size, and now you'll have maybe an understanding of why there's more than one focal spot, because there's two filaments. Turns out that the smaller the focal spot, the smaller the filament size, the better detail we have. Some other characteristics, again, certain screens and certain films are created to either increase the detail, and there are some ramifications as to what your technique will be. as well as just, again, if there's motion, you're going to reduce detail dramatically. Visibility of detail, again, is the ability to visualize recorded detail. In other words, see the detail. So if your contrast and your density are optimized, in other words, they're adequate, then you should have the ability to see the detail. If they are not, in other words, if your mass is too high, too low, or a KV too high or too low, respectively hurting your density or contrast, then you won't be able to visualize the actual detail that's underneath that density. Distortion is our last characteristic, and by distortion, we're talking about a change in either the shape or size of the object. This is caused because of the relationship between the tube, like we have in A, and the image receptor. If you'll notice these images, A through E, you'll see there's several different combinations where something is happening to the bone. Here, one side is being magnified while the other side is being minimized. Notice that there's less OID here than there is in A, so this little part here is a little bit smaller. There's more OID here, so it's magnified, and on. We will refer to these again, but basically they're based on the tube part and/or cassette/image receptor. So while this says film, this can actually be considered just the image receptor. Distortion is also related to the thickness of the patient, the position, and the shape of the object. So, distortion can either come in two forms. It can either change the shape or the size. And size distortion, very similar to detail, is based on magnification. And again, it's the same rule as before. If you increase your OID, you're going to have more magnification. If you increase your SID, you'll have less. Less magnification would also mean less distortion. In many cases, distortion is termed by your level of penumbra. Penumbra, as you see down here, is the fuzziness that's kind of outside of your actual image or surrounds your image. Our optimal images will reduce the penumbra as much as possible. If you'll see in these two images, here this is an example of SID. Right here we have a lower SID, here we have a longer SID. Longer SID is going to give us less magnification, and as you see we also have less penumbra. Also, by the way, the inside here is known as umbra, just U-M-B-R-A. Here's our OID in terms of penumbra. Also kind of like the shadow. If you take a look here, the image on the left has more OID. In other words, the distance between the image and the image receptor is longer here than it is over here. We have a smaller shadow because we're closer, and that's what we want to achieve. One example to look at would be we do a PHS because we want the heart closer to the image receptor. In other words, reduce our OID, reduce our magnification, and increase our detail. This was the example that I just gave you. You can pause here if you want to read this. I'm going to go forward. Here's our descriptions again. Notice I added another little curve here. If our tube is straight, okay, we demonstrate our ball a little bit better. If we angle the tube, we create distortion. We'll get into a second what type of distortion that is because it breaks down similar to the way size and shape does. We can break down shape distortion into either elongation or foreshortening. So, an example of a foreshortened image is one that kind of looks a little bit squashed, as we see here in this first image of the foot, where elongated, which is generally more common in terms of shape distortion, gives you a stretched out look. So elongation is generally occurring when the tube is angled either cephalically or caudal. And we use this on purpose in many cases, so I don't want you to think that all distortion is bad. Right, in many of our views, as you've learned in positioning class, we actually angle the anatomy or the tube because we're trying to move anatomy out of the way. Foreshortening, on the other hand, will occur if our image receptor has been angled, but our tube is straight. And yes, it's possible for both to happen. If you angle your image receptor and you angle your tube, you'll have some kind of combination of both foreshortening and elongation. Okay, excuse me. Pay attention to this schematic. It's a very nice way of realizing that distortion breaks down into size and shape. That size is based on OID and SID, which we saw will change our magnification levels. That shape can then break down into how our alignment is, in other words, the central ray compared to the part, and the angle of the tube. Okay, when it comes to shape again, when we angle our tube, in other words, the direction and degree, we're talking about changing the size, the shape of the image. So in other words, if you angle at an orange, it turns into an egg. Right? We've changed a circular image or a sphere into something that's elliptical. Whereas in here, we are going to just change the size. So again, magnification leads to either a smaller or bigger image, and it should be associated that whenever we increase our magnification, which would be done with a larger OID or a lower SID, that's bad for both our detail and our distortion. So our goal is to always keep the OID as small as possible and increase the SID whenever possible. Again, this is the rationale for doing a chest at 72 inches versus doing it at 40 inches. So the image on the left, unmagnified, this is the one with a little better detail. There is certain reasons why we might magnify an image, and in the CR-DR world, there is the ability to certainly turn a knob, so to speak, and increase the size of an image, but even there you are losing a little bit of detail. All the pixels get stretched out, you have less pixels, and thus you have a worse image. Well, I hope you've enjoyed this lesson.